Good evening, one and all.
Good evening, Dr. Arun.
Yes, Arun. Dr. Saju is here. I think people are joining. I think the chairs for this particular molecular tumor board will be Dr. Krishna Kumar Ratnam and Dr. J. Kannan. So Krishna Kumar Ratnam is from Madurai Meenakshi Mission and Dr. J. Kannan is from Madras Medical College. And this is our ninth series. So successfully we have done almost some 4 months now. So we have discussed almost close to 72 cases, almost 8 cases per week. Every 2 weeks we have discussed, except for one series where we discussed only 7 cases. So a lot of efforts are there. I thank all the admin people, particularly Dr. Kripashankar, Dr. Narendran, Dr. Saju, Dr. Chandralekha. So all of them have put a lot of efforts to coordinate this particular program. And I thank all the experts who have joined from various laboratories. Every time they join, take time. And on a weekend, 2 hours is always difficult. So they've taken time to share their expertise with us. So I thank all the experts. With this, I welcome all the participants and we'll go to the first presentation. First presentation will be from Amala Institute of Medical Science, Thrissur, Dr. Anupam. For the whole session, for today's session, Dr. J. Kannan and Dr. Krishna Kumar will be the chairperson and they will give their inputs. And Dr. Narendran will summarize and we'll give 15 minutes for each session so that we'll have ample time for discussion for all the cases. Thank you. Over to you, Dr. Anupam. You can start the presentation.
Good afternoon to all the respected faculty members. Myself, Dr. Anupam. I am a first year medical oncology resident at Amala Institute of Medical Sciences, Thrissur. My case is a patient, 63-year-old female. She presented with fatigue and body pain. Family history has a carcinoma stomach in her mother at 85 years. She's postmenopausal since from 45 years. Good PS1 and presented with complaints of right breast central quadrant, ulcerative lesion 4x6 centimeters with bleeding on the sides. Axillary lymph nodes were present. So biopsy showed invasive carcinoma and immunohistochemistry. ER was weak positive 30%, PR was negative, and HER2 was 0. Ka67 was high. Next slide. PET-CT showed spiculated soft tissue lesion in the upper inner quadrant of right breast involving the overlying skin with retraction. There were multiple enlarged right axillary and right subpectoral lymph nodes. Multiple bilateral lung mets were also there, and multiple ill-defined sclerotic lesions in axial and appendicular skeleton were also there. So, and there was no other lesion elsewhere. So, features suggestive of locally advanced right breast malignancy with axillary, subpectoral lymph nodal, pulmonary, and skeletal metastasis. So, her comprehensive hereditary panel was done, which showed no pathological variants, and she was started on ribociclib and letrozole and Q3 monthly zoledronic acid. In a PET-CT done in, and it was started in April 2025, and PET-CT which was done in July 2025 showed disease progression and with a newly developed hypodense lesion in segment 6 of liver. And the other lesions were stable, bone lesion, breast lesion, and the lymphadenopathy. She had worsening LFT with thrombocytopenia looming around 75,000. So repeat biopsy was not done from liver or marrow. And at that point of time, she was considered as visceral crisis and started on weekly paclitaxel. And NGS, MSI, and PDL1 were sent. And palliative RT 20 gray in 5 fractions was given to the breast lesion to cover for the bleeding. She had good PS, but platelets were around 65,000 to 80,000 during weekly paclitaxel. And so she received it with some delays. Next slide. And the HRD status came to be positive. MSI was stable and the TMB status was low. Next slide. There were no other than HRD positive, there were no other outcome from the NGS report. Next slide, please. Her PDL1 showed CPS raw score as 1. Next slide. So then we added cisplatin, weekly cisplatin to the weekly taxane. I received total of 9 cycles and a total of 8 weeks of cisplatin along with the taxane. Latest liver function test showed total bilirubin to be 1.7, SGOT 130 and SGPT 156. In the hemoglobin of 9, total count of 8,000 and a platelet count of 75,000. So, and actually, we had done a PET-CT scan last like 3 weeks back and a bone marrow biopsy. And the current PET-CT, it is not included in the slide, but the current PET-CT had showed a partial favorable response. All the lesions had a partial favorable response. And a bone marrow biopsy was also done, and the report is showing metastatic CA breast. It just came like 30 minutes back. Then the points of discussion will be any role of addition of any immunotherapy, and whether PARP inhibitor can be given considering the status of the thrombocytopenia, and should any repeat biopsy be tried for this patient. Thank you.
Thank you. Thank you, doctor. So to summarize, the metastatic breast cancer who
Yes, sir.
progressed on ERPR positive and
ER positive, ER weak positive, PR
weak
negative,
positive, PR
BRCA
negative,
Yes.
progressed on ribociclib and letrozole,
Yes, sir.
and responded to taxanes and
Okay.
cisplatins.
Okay.
So if you see the NGS pathway, HRD is positive,
Sorry.
but TMB, MSI, and PDL1 is low, so it's a cold environment. And TP53, I think it's positive, significantly positive. So that is hereditary panel is negative. So this is the NGS panel. So the question is, what is the role of PARP inhibitors, particularly HRD positive, but we don't have a germline BRCA mutation in this particular case. So what is the role of PARP inhibitors in BRCA negative but HRD positive breast cancer? This will be the first question. So any experts would like to take the question? Okay. So I'll just tell somebody, Arun Kumar, or somebody wants to give their thought. I'll just give my thought. See, whatever the approval that we have got, for the students here, the approval for PARP inhibitors is different for each cancer. If you take the ovary is most of the trials are designed around HRD. If you take the prostate, most of the trials are designed around the HRR gene panel. If you take the biliary tract and gallbladder, hepatobiliary, breast, most of them are BRCA and BRCA1 and BRCA2. So that's how the trials are designed. So the approval, whatever we get is based on that. But I did have some few cases. There are some phase 2 trials where HRD positive, BRCA negative, although the approval is not there, still there are a good number of trials to show that benefit will be there even in this particular setting. So one of the studies showed almost 50% response rate in this particular setting. So yes, for me, patient is already doing well with platinum. Probably this is weak ER positive, so it's behaving more of a triple negative subset. It is responding to platinum, probably consolidate whatever the response we have. And then probably once platinum is over, then nothing wrong in continuing maintenance PARP inhibitor. But we know most of the PARP inhibitors, thrombocytopenia, anemia will be further increased. But if it's a disease-related thrombocytopenia, probably continuing platinum and taxanes, probably the thrombocytopenia should improve in this case. Probably we can think of adding L-thrombopag also, so that we can maintain the dose intensity in this case. This is what my thoughts. I think Arun is trying to tell his point. Yes, Arun, you can go.
Yeah, thank you, Dr. Arun. I think bottom line, I'm also for PARP inhibitor here. But I just want to show the focus on the other gene mutations that was there in this particular report. Can you just go to the amplifications that we're seeing, the NGS report? I think the previous slide, just one before this. Perfect. Yeah, this is the one. So one is that this is a HRD positive, but this is a lab developed test. So that this is a 80 is a pretty high score. Now, generally, when you have such a high HRD score, which means genomic instability is so high, you tend to find some kind of a causative reason being a germline mutation, typically a BRCA mutation or something, but we don't find anything here. We just see one VUS in the RAD51C, which is there in the next part of the report, the next slide. So I think that is currently classified as a VUS. Not sure really if that is the one that is causing this HRD. But given that the patient is also a bit sensitive to platinum, I think this is this seems to be really some genomic instability component is there. So this is part one. Second one is this TP53 arginine 175 to histidine mutation. It's a pretty high VAF of almost 70%. Two things, it could really be a somatic mutation, but there are case reports of the same mutation to be a germline in nature causing leaf romany. So yeah, maybe that is another angle that one may want to take it forward. This exact mutation has been described in many cases of leaf romany syndrome. So that is one point you would want to take. The third is these gene amplifications, MYC, MCL1, and SGK1. Now, of the three, SGK1, we really do not know any therapeutic or prognostic relevance to it. It's a glucocorticoid regulator. So how it impacts the therapy or something, currently we don't have any such thing. But MCL is a gene that is involved in apoptosis BCL2 regulation, that is known. But coming to MYC, now close to 60% of triple negative breast cancers, particularly the basal type, tend to have a MYC amplification. Now, MYC is a pretty notorious gene here. Now, I'll also try to answer the next question of immunotherapy here, which of course CPS score is just one. In triple negative breast cancer, CPS of 10 and above is approved for pembrolizumab. Nevertheless, the tumor environment would be cold because of MYC. Now, the thing is that MYC also induces platinum resistance. If you find MYC in ovarian cancer, if you find MYC in, say, any other tumor, even lung and small cell, multiple studies in different tumors have shown that chemo resistance is induced by MYC gene amplification. Now, particularly in triple negative breast cancer, that has been shown. So how it is doing that? There are a couple of, or rather multiple cellular targets of MYC that causes this resistance. So MYC overexpression leads to better DNA repair. In contrast to what we expect in a BRCA mutated or a RAD51 mutated tumor, MYC leads to better DNA repair and faster DNA repair. And it also has an impact on CDK cyclin-dependent kinases so that cell cycle is unregulated and it goes much faster. So at the point where platinum induces apoptosis through cell cycle inhibition, MYC tries to prevent that. So whenever you find MYC, always have there is a very high possibility that the response to chemotherapy is going to be poor. Having said that, the patient had some decent response to platinum here, which is why I also need to see the copy number of the MYC. So these are my takeaway points. One is that MYC is a definitive cause of chemo resistance. Second is TP53 mutation. This particular mutation has been shown to be associated with leaf romany. Worthwhile to test that also, maybe by a Sanger in a buccal swab of the patient. Third, it is HRD positive and partially platinum sensitive. So it is worthwhile to, after platinum therapy, worthwhile to see the use of PARP inhibitor.
Thank you. Thank you, Dr. Arun. And yes.
Yeah, Kripa here, sir.
Yes, Kripa.
I mean, like, to me, this patient has got primary endocrine resistance, even though it was ER low positive to begin with, progressed within 3 months of endocrine therapy and CDK4/6. So it's been behaving like a triple negative breast cancer and now is responded to platinum. The question here is probably, maintenance as, we know that it's not yet approved as maintenance, so it will become at best an off-label indication. So, the other options are again capecitabine, eribulin, all of those drugs, because this is the first line of chemotherapy that the patient has been exposed to. And patient has had pretty, a thrombocytopenia, which could most likely be drug-related or related to the platinum, myelosuppression. So I think, like we were rightly pointing out earlier as well, sir. They're looking at HRD as a tumor-agnostic marker as well. The Lodestar red data as well, but in those patients, the response rates are close to 30%. But then again, I think as of right now, it stands as an off-label indication right now. I think maintenance, for me, I think I would continue with the platinum. Go ahead, because the patient seems to be responding to a platinum-based doublet here and treat it like a triple negative breast cancer. And probably, post multiple lines, because, if the patient can afford Saxi, capecitabine, eribulin, all those options later, then probably, look at using BAP inhibitors later. I probably wouldn't be too keen to put the patient on PARP inhibitors, given that, I agreed, like Arun sir also was tell us, this HRD score is an LDT. And we have 3 different types, GIS, GSS, and GAS, genomic instability score, genomic scar score, and then the genomic aberration signature or the aberration score. So I think each one of them have been standardized in their own ways. Nevertheless, the reproducibility seems to be good. The concordance is close to around 80 to 90%. So I think going based only on HRD right now in the first line, this is probably the first line of chemotherapy that this patient has been exposed to. Probably might be too early for me to do that as maintenance therapy. Probably, and again, the other pathways that have been involved here as well means that probably this is a slightly cold tumor microenvironment, as was rightly pointed out earlier as well. It's not a very hot tumor microenvironment here. So those are my.
Yes, Kripa, my only, what is your take? See, if a patient is having Taxol platinum, after 6 cycles, patient is having a good response. Would you like to switch in this case to capecitabine or reserve capecitabine for later date and incorporate PARP here because of the HRD positivity?
I would probably not put the patient on probably any maintenance here. So I would probably just, wait until progression and next line start off on maintenance. A second line therapy with eribulin cape, eribulin plus cape, or any of those combinations. Even in the second line setting, or if the patient can afford it, I would treat as a triple negative like saxituzumab govitecan becomes another option as well. That's also an approved option. So if you exhausted all of those options, maybe then I would look at placing the PARP inhibitors based on the HRD alone, because for the single reason being that it's too early for us to look at off-label indications now. Because right now for this current indication, this becomes an off-label indication.
Absolutely, fair enough. Very fair enough. Okay, anybody else? Any other thoughts?
Arun, my thoughts are it's look like more of a triple negative behavior.
Okay.
So when the patient showed only partial response, so I would like to give some form of treatment for control the disease.
Okay.
So I will start with capecitabine at this juncture. Once the platinum and paclitaxel is completed 6 cycles, means that cycle for quite some time, then I will give some form of therapy. Otherwise, immediately, I think Ka67 is also high in this patient.
So, Dr.
immediately the patient will progress.
You will complete the platinum, then you will put on maintenance capecitabine for this particular patient.
Surely, because it's a stage 4 disease. Yes, it's stage 4 disease, and then more Ka67 triple negative, this patient will behave aggressively.
Okay, fine. Dr. Arun Kumar, one more question. Actually, the presenter has kept his role of repeat biopsy now from the liver.
Yeah. I think it's too early now. This biopsy is from the breast, is it?
Yeah, I think so.
Yes.
Upfront, not from the liver.
I would even be fine with doing a liquid biopsy if required.
Okay.
Yeah.
Okay. Fine. Anybody else want to have want to share any thoughts? Anybody else? Okay.
Sir, Dr. Pushpa here.
Yes, ma'am. Yes, ma'am.
So here, as germline tendency is also there, and the tissue has been done for the somatic testing. So I would recommend going on for a germline testing also to confirm the germline history of this, family history of this patient.
Okay. Fine, ma'am. But my only thing, like to all the molecular pathologists, see one of the caveat, like even recent ESMO on NGS, they said for progressive cancer, P53 is the commonest mutation they see, and many of the time the VAF is so high, unless there is some phenotype or multiple malignancies. Better to avoid germline mutation, particularly when P53 is present in the tissue. So, is there anything like that? What is your thoughts? Because most of the cases, particularly later lines, when we do the NGS, we see a lot of cases having high VAF, particularly P53.
Yes.
So nothing
Yes.
turns into be leaf Romani actually till now. Unless you see some phenotype or multiple family history of malignancy, patient is having multiple malignancy, should we really go for the germline testing?
So here I am not very particular about TP53 being highlighted, because TP53 is not only highlighted more in the reports for showing high VAF at this panel, where everywhere we are getting T53 now, sir, whether it is germline or somatic. So keeping that in point of view is not my consideration. My consideration is we can see a family history being there available. Looking into the family history of
Correct.
GI involved and breast involved here.
Okay.
Considering that line of no inheritance, do we really no, again, it's just a suggestion. Should we need a germline testing here further again?
But here in somatic, we haven't identified. Is there?
Yes, that's why I'm saying, keeping that point of view, since in this panel we cannot identify the germline mutations most of the times, because they only with the higher VAF we consider whether it is aligned towards the germline or the somatic. So literally going for a liquid blood test, basically the germline panel will be sorting out the no conflict between this germline or this one. It's a cancer heritable or no.
It's a very interesting point, actually, what you said. See, HRD is positive. We couldn't identify the gene per se, and this is a behaving like a triple negative subset. Probably NGS is missing something. Doing a hereditary panel will
Any
help
of the
us particularly.
alterations, in a
Particularly,
maybe
yeah.
listed.
So, anybody else would like to do a germline testing in this case when somatic tissue is negative?
So, Arun sir, probably I'll take that up.
Yes, Kripa.
If you're thinking of leaf Romani and if the patient fits the COMPRED criteria, probably yes. We call it the SBLA syndrome, sarcoma, breast leukemia, adenocarcinoma.
Yes.
So if at all patient fits into the COMPRED criteria, strong family history, all of those, then probably worthwhile doing a germline testing. Otherwise, I'm not too inclined towards doing that, number one. Another thing is, probably if you're putting this down as ER low or triple negative, it'll be interesting to look at what molecular subtype of triple negative. Is it a basal-like or luminal, or basal-like immune activated or basal-like immune suppressed? So this to me looks like basal-like immune suppressed, because here the tumor microenvironment is not hot, it's cold. And also this looks like a basal-like of TNBC as to how it's been behaving clinically as well. So I think those are just my 2 cents as far as looking at the molecular subtypes of TNBC in this particular patient. And if in case they want to look at repeating a biopsy for tumor heterogeneity or discordance as well, because clearly it's been behaving like a TNBC with primary endocrine resistance with ER low positive and progression within 3 months of CDKN hormonal therapy. So I think that's, those are my 2 cents. Sir.
Okay. Thank you, Dr. Kripa.
Sir,
Yes.
Dr. Anupam here. Sir, one doubt whether immunotherapy can be, considering the cold environment, will it be any of use in this patient?
I think immunotherapy definitely not an valid option here. Your CPS is not high. Your TMB is low. There's no MSI, and we know the approval in triple negative breast cancer is for patients who have a CPS of more than 10.
Sure.
So I think here, clear cut, there's no role for IO here.
Okay.
Thank you.
Okay, thank you. So I think since Narendran is not here, Narendran, you are there? Okay, he hasn't joined. So I'll just summarize. Yes, Narendran, you are there. Yeah, you can summarize.
I'm joining between, sir, so I missed this case.
So, okay, I'll just summarize here for you. So in this case, the consensus is we will continue the platinum-based chemotherapy. We'll try to consolidate whatever the response we have got. One. As far as the maintenance is concerned, yes, there is we can give a break and restart the chemotherapy on progression or continue maintenance capecitabine in this particular case. Maintenance PARP inhibitor, not now because it's not a labeled indication. Probably reserve that for a later date. That is the third point we have discussed. And fourth is repeat liquid biopsy. Now, because the patient has progressed, upfront we have done a biopsy and we have sent for molecular testing. Now, repeating a liquid biopsy probably can throw more light in this particular case. And since this particular patient is behaving more like a triple negative subset, if possible, we can do a hereditary cancer gene panel in this particular case. So these are the thoughts we got. I think any doubts, Dr. Anupam? Anything you want to clarify? Or shall we go to the next case?
Thank you, sir.
Thank you very much. So we'll go to the case 2. Case 2 is again from Amala Institute of Medical Science. Dr. Ritu will be presenting the next case.
Good evening all. Myself Dr. Ritu. I am second year resident medical oncology from Amala Institute of Medical Sciences. My case is a 55-year-old lady from Palakkad. She was evaluated for a breast lump since 1 month duration. No other associated history. Can you move to the next slide, please? Her mammogram showed a BRCA 4C lesion measuring 2 into 1.7 centimeter with few lymph nodes in the axilla, largest measuring 1.7 into 1.5 centimeter. Next slide.
Tamil, go to the next slide, please.
Yeah. Her biopsy was reported as infiltrating ductal carcinoma. A PET CT scan was done, which showed the primary carcinoma breast with axillary and deep pectoral nodes. And another finding was a lesion, a soft tissue mass in the upper pole of left kidney, favoring a synchronous malignancy, a renal cell carcinoma. And there was a mild left pleural effusion and a FDG avid hypoenhancing lesion in the lower pole of left thyroid lobe. Left side, Cori mesenteric cyst or a ovarian cyst. So she underwent a radical left nephrectomy with oophorectomy and MRM. So the histopathology of the nephrectomy specimen came as renal cell carcinoma with extension to the renal cell, sinus and pelvis. And nodes dissected 15, all were negative. So it was a PIK3CA. Next slide. And the paratic node dissected was also negative. The oophorectomy specimen came out to be a mature teratoma. The MRM specimen HPR was reported as invasive carcinoma grade 2, and there was no LVI, and margins were all free. And out of the 19 nodes dissected, 6 was positive, and there was a metastatic focus measuring 1 centimeter. So it was a PT2N2A CA breast post MRM. Next slide. So the thyroidectomy specimen came out to be a papillary carcinoma classic subtype with no LVI, PNI capsular invasion, and node dissection was not done. So it was a PT1A NX. So IHC was advised and genetic studies were suggested for some mutations. Next slide. So the IHC from the renal cell carcinoma suggested that there is no specific subtype, and they advised some mutation studies. Next slide. From the breast cancer specimen, the IHC turned out to be triple negative. So a comprehensive hereditary panel was done, which found to be have no deletion or mutations were detected. Next slide. So considering this as a triple negative breast cancer with the RCC, she was started on like adjuvant chemo with AC and pembrolizumab was added from the second cycle. So like our points of discussion are in this hereditary panel, we couldn't find any mutation. So what could be the next best plan for this patient?
Okay. Thank you, doctor. Can we know what exactly NGS panel that was done? So what all the gene mutations were covered? Yeah, please. So this is medgenome. Okay, go to the next slide. Okay, fine. I think we'll go directly to the expert. So yes, a patient having multiple primaries One is triple negative breast cancer, another is papillary thyroid cancer, PT1A NX, another is renal cancer. So PT3N0, that is the renal cell carcinoma. So all operated at single setting. So the question is, hereditary panel is negative. How to go about? Yes, Dr. Arun Kumar, Dr. Brinda, anybody else want to take this question? Are we missing something here in this particular case? 3 malignancy in one patient, but we couldn't identify a mutation in this case.
I'm just thinking out loud here, no opinion, but I definitely I think there is something is being missed here. 3 malignancies in the same patient, unless and until there is some carcinogenic insult that has been there in the patient due to the lifestyle. Otherwise, I think 3 malignancies, there should be some genetic background.
Arun, can you just explain that carcinogenic insult so that people can understand what you are really thinking loud actually? So that,
sorry, no, what I mean is some kind of chemical exposure or something.
Yeah, during pregnancy or
during pregnancy or during
that's possible.
Yeah. So if that is the case, then multiple malignancies can be seen. Otherwise, there has to be a genetic rationale for it. So one thing I would suggest is doing maybe a liquid biopsy, or if there is enough tumor burden in the body. If not, whatever is the most recent available tissue or tissue CGP must be done as somatic testing. That can also tell us what type of mutations are there.
Was this gene panel done in the blood? Hereditary gene panel in the blood, right?
Yes. Yeah, that would have been done in the blood. Yeah.
This is blood. Whatever the genome, will a somatic mutation testing, if at all it's a mosaicism or if it's happening teratogenicity or carcinogenic insult affecting certain tissues alone, it will be picked up if we do a NGS panel on the tumor tissue, right? So that will help, right?
Correct. That will help. So the difference is that the DNA is extracted for germline for testing from the WBCs, from the leukocytes. Whereas when we do a liquid biopsy, it's extracted from the plasma. That is the liquid portion of the blood, under the assumption that DNA from the tumor is getting shed into the plasma. So yes, ideally, if the tumor content is high and the mosaicism, even if it is there, I know as low as 25-30% variant allele fraction can also be picked up in germline testing. But maybe there was some challenge with the cutoff at the time of bioinformatic analysis. We don't know. So which is why I'm suggesting a somatic testing so that even the lowest amount of variant allele fraction variant can be picked up.
No, one of the chat box, they've asked which tumor tissue to be breast, thyroid, or RCC will you test?
That's why I wanted liquid
Ideally
biopsy.
all. Ideally, in this case, all.
Yeah.
Ella, in this case, if after speaking to the attender, at least in academic sense, to be honest, last time when on primary we couldn't detect, we had an extensive discussion. Dr. Surchi was so nice. So academic sense, she got it to her laboratory. She did free of cost for the patient. That is so nice. So this is a very good academic case. If one of the lab is interested to do that, it will be excellent actually. So ideally all 3 to be done so that we'll see what we get from that.
Yeah, or at least to start with the TNBC specimen, breast specimen can be right.
Fine. Anybody else want to share any other thoughts?
So in this kind of complicated cases, generally a concurrent testing will be a better choice. Doing both on tissue and blood simultaneously.
Yes, that's a good option. Yes,
it's a good option. That's good. Okay, thank you. The next question is, I think, clinical platinum. Yes, it's a node positive case. I think all of us will add platinum in this. So patient missed that neoadjuvant preoperative pembrolizumab. So adding pembrolizumab now, will it benefit both? Is anybody else want to take this question?
So yeah, I think Kripa says. So I think I would look at adding pembro, given that it's probably because it's stage 3 RCC for the RCC as adjuvant therapy qualifies. I think T3, it was T3 if I remember right. I think was it? Yeah, it was T3A. So
yes,
it becomes stage 3, and the patient does qualify for the Keynote 564 as far as the inclusion criteria is concerned, and it's an approved option as well. So yes, I think probably yes. And I know in triple negative breast cancer, the ABRAVE data, which is for adjuvant avelumab alone, and the primary endpoint of the trial was negative. DFS was not met, but overall survival was positive even in that study. Nevertheless, it's not an approved option in the adjuvant setting alone for triple negative breast cancer. But as far as the RCC is concerned, I don't see any harm in adding it or giving it as adjuvant therapy for the RCC.
Thank you, Kripa. Anybody has second thoughts in adding IO in this particular patient? Okay.
So do you want to add an IO after doing the NGS, Dr. Kripa, because it's multiple malignancies here?
Not really, sir, because I think if you look at it for RCC, the adjuvant setting, it's the approval is irrespective of the mutation. I mean, like it's not based on just the histology alone, and here it's a clear cell histology. I mean, like based on the report that they've mentioned, it's a clear cell histology grade 1, or Furman's nuclear grade is 1, and whatever germline testing that's been done already hasn't picked up any of those fumarate hydratase or STH or any of those other genes that have been checked.
Yeah.
So
yeah.
So I think we don't need a particular thing to start off on just on pembrolizumab as far as adjuvant treatment of RCC is concerned.
Thank you, Kripa. I think we all agree with that. I think adjuvant is not going to be decided based on the NGS report. It will be decided on the patient's financial status. I think that's what is going to decide. Thank you. Naren, can you summarize?
This patient with 3 different cancers, one is TNBC, another is renal cell carcinoma, and the thyroid papillary carcinoma. All 3 surgery done, and germline hereditary cancer panel has not picked up any of the genetic mutations. So the final consensus after the expert's opinion is may consider a somatic mutation panel from all the 3, and to go ahead with the AC and with the taxane and add carboplatin also. Since it's a renal cell carcinoma, there's indication for pembrolizumab. Could consider pembrolizumab as adjuvant, which may help in breast cancer also here.
So ideally, to do a tumor normal match as well, Narendra. Tumor normal on both liquid and tissue. Agreed.
So liquid biopsy and tissue.
Correct.
Yes.
Correct.
So instead of doing all the 3 somatic mutation, whether we can go ahead with liquid biopsy alone here.
No, may not be sufficient. You'll need probably both.
No, because there's no metastatic disease. Once all the 3 surgery done may not help to get a good yield, probably.
Yeah, because in the adjuvant setting, this is all in the adjuvant, right? I mean, like,
so if it's metastatic disease, it would have helped, not here.
Exactly.
Correct. Yes. Thank you, Naren. I think Dr. Pushpa, she had some thoughts.
Sir.
Yes, you can go ahead.
There has been a study which is done including normal match. So where when it is done on tissue liquid as well as the normal cells, PBMCs basically taking that, the sensitivity of detection of the variants will go high. So even we have missed something there in either tissue or blood, by comparing the sensitivity of the detection will go high here by doing normal match. Maybe for this case, as Sir said, tissue liquid as well as that is concurrent testing along with the normal match will help in yielding the good results or better further treatment guidance here, sir.
Agreed.
Thank you.
So, can you just say what is the normal match, and this is confusing at the end. So can you just say what you suggest here? So we do pick from all the
normal,
3. Yeah.
Yes, sir. So normal match is something where you generally what we do is whenever we have any variants, we compare to the reference genome, which is population based basically. But here, by doing normal match, we are comparing the mutations to the person's own genome. So here, by doing that match, we are able to understand the pure segregation of what are really true somatic mutations, what are really true germline, which cannot be done by only by considering the VAF most of the time. So normal match is basically meant to have a segregation done. And by this, by doing it on all the 3, like a lot of the times it happens that whatever we miss in the tissue may be captured in the blood due to heterogeneity again. So that is how the detection of the variants also will go high, and that segregation will improve the sensitivity, whether it comes for your TMB, in the sense tumor mutation burden. Whenever we calculate, all of you agree that it will be like pure somatic calculation. But however, we will not know whenever we calculate a TMB whether it is pure somatic or true germline what we are calculating. So by doing this normal match, we are able to actually get what are the pure somatic mutation for the calculation of TMB, which the TMB sensitivity also will go high here. That is one one of the
labs
examples.
do the normal match here? Do all the labs do normal match if request?
Not all.
I didn't get you, sir.
He wants to know if all the labs are currently doing a tumor normal match. No.
I think Tempus is doing with tissue and normal match, or liquid or normal match. Tissue, liquid, normal match, actually one cell is doing.
Okay.
Yeah, and is also offering it the access. I mean, sir, there are a few people who are offering it right now, and also helps rule out mosaicism chip if it's a chip or not.
Chip mutation also. Yes.
Thank you.
Basically, based on the VAF, they are differentiated, whether it is to germline or it's a chip based on the variant allelic frequency, because chip generally occurs with the very low allelic frequencies.
Thank you, Dr. Pushpa Singh. I think this case, I think some of the postgraduates are here. So I just ask just Arun Kumar to just brief exactly in this case, we are thinking of something germline is happening, but our testing did not pick up. So we thought probably some carcinogenic insult or mosaicism is there. So we have advised. Can you just, for the postgraduate centric, can you just tell how this can be, like how it is, all these tests, whatever we advise is going to help? Some basics alone, can you just tell for the postgraduate point of view, Dr. Arun?
Sure, sir. Yeah. So basically, we need to understand two types of NGS we do. One is for somatic testing, where the depth of sequencing is very high, somewhere around 500x, meaning we sequence every base 500 times or more. The other type is the germline testing, where we sequence it at around 100x depth, 100 to 200x depth is what we do. Now, what we are suggesting here is, because the hereditary cancer panel, which is a germline testing, did not pick up any variant, we want to see what are the other causes of variants, mutations that can show similar picture. One such cause is what is called as mosaicism, meaning that the mutation is there in certain cells of the body, but not in all the cells of the body. So that mutation typically happens when after the zygote is formed in certain cells, or because of a carcinogenic insult, there could be mutation in certain tissues of the body, but not in all the tissues of the body. So to differentiate mosaicism from actual germline, to differentiate chip mutations, to identify if there are any other mutational signatures, both somatic testing as well as germline testing will be done, which is what here we are calling as the tissue matched testing, or germline matched testing. So data from somatic and data from germline NGS will be compared, and all these factors of mosaicism and others will be picked up. It's a very unique case because
Thank you.
We typically identify germline mutations in these multiple malignancies.
Thank you. So basically the hypothesis, what we are trying to tell is there is a germline mutation is there, but it is not picked up by checking the WBCs. So probably there is some common insult that is happening in the thyroid, ovary, renal, kidney, and the breast. But it's not happening in the WBC. So that's why when you do the when you take the WBC and check for germline, it is missing. But something else is happening in these 4 tissues, which is not picked up. Probably that's why all these added extra test is being done. Thank you. Thank you very much. We'll go to the case 3. Over to you, Dr. Ramakrishnan.
Good afternoon, all. My case for today is a 58-year male, primary site, cancer site is CA colon stage 3. The patient underwent, next slide please. The patient underwent post total colectomy, pathological staging T3N1 adenocarcinoma. Next slide please. The patient pathological staging T3N1 adenocarcinoma, microsatellite stable disease. The patient received adjuvant 6 cycles of capox followed by 2 cycles of capecitabine. Now the hereditary cancer gene panel showed MSH6 exon 5 variant of uncertain significance. Next slide, please. Now the patient has complete response and the patient is currently on follow-up. So now the question for is next slide. Next slide. This GS report showed MSH6 exon 5 VUS. So now the significance of MSH6 in this case, particularly this is a MSH stable disease, and even if the patient is currently on follow-up, if the patient comes off with recurrence, should we repeat MSI IHC we should look for, or is any other clinical significance for this stage?
Why this patient hereditary
Thank you.
panel was done?
Sir?
May I know why this patient hereditary cancer panel was done? Because of family history or?
No, sir, no family history. The patient who wanted to no, sir. Patient wanted to do wanted to know whether any risk for disease, any genetic group.
But there's no family history, right?
No family history, sir.
Okay, thanks.
Thank you, Dr. Ramakrishnan. Actually, so
Okay.
I will. I think if Brinda is there, she can take the question. Otherwise, we'll go.
Yes, doctor.
Yes, Brinda.
Yes.
How do you...
One thing is this is a VUS, so we could consider IHC, but should we also reconsider PCR angle, the MSI PCR is something I would reconsider.
Okay.
Dr. Arun, your thoughts, please.
Yeah, I mean, I would prefer doing an IHC first, because if this is a pathogenic mutation, there should be a loss of function and it should not get expressed in the tissue.
Yes.
So definitely a screening with IHC would be suggested.
Okay.
This is the MSS stables, the tumor tissue MSS stables.
Oh, MSS stable. Okay.
Yeah.
In all probability, this is not a pathogenic variant, but nevertheless, you can still do a DMMR testing, MMR
Okay.
by IHC, because in a very few number of cases, you do have a discrepancy between MSI and MMR status. Very few number of cases. So just to cover that base also, I would really suggest doing a MMR IHC.
Okay. Thank you. So basically, there are
Yes.
3 ways to check MSI. One, we do IHC, then we do the PCR, and then
Sir?
Yeah, I can't hear Dr. Arun.
analysis in this particular case. That's what, because what we all want, the patient is want to know whether it's a familial. That's why patient has
Sir,
done
we
this.
lost you for 2 minutes, sir. Last 2 minutes we lost you, sir. We couldn't hear you.
Okay, fine. See, the patient want to know whether it's a familial. This is the question. So
Yes, sir.
first, we need to do a counseling. If the patient understands what is the significance of views they want to proceed, probably we need to do a confirm it by MLPA. And if it's still VUS is there, it is positive, probably we need to do a segregation analysis to see how significant this is. Otherwise, we need to leave that and proceed with the standard of care what we generally offer. We should not give much significance to this. This is what I think. Anybody else? How do you manage this VUS in your clinical?
I think obviously genetic counseling with the patient is very driven, and also the strong family history. Getting it reported and then follow it up as any change in the VUS to probably when it becomes pathogenic or likely pathogenic in the future. So I think agreed with whatever you're saying.
Thank you. Thank you, Dr. Kripa. I think Naren, can you summarize? We'll proceed.
This patient is stage 3 CA colon, post MSS MMR proficient, post chemotherapy and follow-up. The genetic test picked up VUS or MSH6. So since there's no family history and MSS is stable, as of now, this patient, there's no therapeutic implication. to follow up. This is a suggestion.
Thank you. Thank you. Dr. Kannan, you have any other thoughts? We'll proceed with the next case, Kannan. Okay, we'll proceed with case 4. Case 4 will be by Dr. Mangai from Kaveri Hospital, Trichy. Over to you, Dr. Mangai.
Yes, sir. Good evening, everyone. So today I'm presenting a patient who is a 62-year-old male. He is diagnosed as melanoma. He had a right foot skin lesion which was excised in 2012. So after that, he had a recurrence. So after that, patient is now currently on treatment. So he has comorbidities of hepatitis C positive, and he has a anti-HBC total alone positive. So for that, he's under treatment, and there is no significant family history. In 2012, he was diagnosed as melanoma, and the lesion was excised. We don't have the details of the treatment per se. So after 12 years, in Jan 2025, he presented with pain abdomen, and on evaluation found to have abdominal nodal masses and inguinal nodes and bone lytic lesions. He was treated with one history is he also underwent a decompressive laminectomy at that time during January, then subsequently treated with 3 cycles of dacarbazine cisplatin, and since there was no symptomatic improvement, they have switched to nivolumab ipilimumab. So he was completely treated outside. So after 4 cycles of nivolumab and ipilimumab, PET-CT again he had a progression only. So that progression was in the D4, D5 spine site also. For that, again, a decompressive laminectomy was done. Then in this meantime, there was a 2 months gap. A repeat PET was again done, which was also showing a disease progression. So he was given palliative RT to the spine lesion and another pelvic bone lesion also. Currently, patient is on temozolomide. Next slide, please. The tissue is a inguinal node biopsy in which we had sent for a NGS panel. Next slide, please. Can you show the report? Yes. So the tissue NGS is showing a NF2 mutation with a VAF of 50%, and the other mutations are other genetic aberrations are copy number variations. TET copy number gain, and FGFR3 copy number gain, BRAF copy number gain, and next slide, please. He also has a CCND3 and CDKN2A to B copy number loss. So my questions to the board are whether this, how significant is this NF2? Should we do a germline testing for this patient? And based on this, if he has progression on temozolomide, what are all the further treatment options for this patient? Thank you.
Thank you. Thank you. Thank you, Dr. Mangai. I think it's a quite complicated case. So yes, anybody wants to start? Okay. Yes, sir.
Maybe I'll
Yes.
dissect the molecular report and try to answer these questions one by one. So as I understand, the patient has been previously heavily pre-treated, right? So there has been platinum, there has been immunotherapy, and in spite of that, I think the patient is progressing, and currently the patient is on temozolomide. I just wanted to know what was the rationale for temozolomide in this patient? Was it molecular driven, or is it a standard of care you wanted to explore? I'm not sure of that. Or was it because of NF2?
No, sir. Prior to the report only, we have started on temozolomide. As a patient was actually, we have very limited options after progression on immunotherapy, sir. So
yeah,
oral therapy, we started temozolomide, sir.
Oh, okay. So it's more of that. Okay, thank you. So I'll just try to dive down into this report, wherein first what we see is this NF2 variant. Can you just go to the report, please, for everyone to see? Previous slide. Yeah, just come down. Perfect. So this NF2 is a negative regulator of EGFR pathway, so RAS-RAF pathway. And NF2 is a negative regulator, which means that when NF2 is lost, the RAS-RAF pathway gets activated, and NF2 also activates in a very similar way negative regulation of PIK3 pathway, PIK3AKT pathway also. So the VAF of exactly 50% is quite interesting. I believe this is a tissue-based report. Probably germline origin could be there. Nevertheless, I'm not going into that right now. In terms of targeting NF2, different precision oncology studies, they have tried to target NF1 and NF2 losses using a MEK inhibitor. Now, addition of, I'm purely talking based on molecular nature. I would really leave it to the clinical experts to see if that is viable. So what I'm MEK inhibitor can support this NF2. It can also help with the BRAF amplification. Now, BRAF is amplified. We really do not know if all BRAF amplifications work the same way as the V600E mutation, but still, when BRAF is amplified, definitely the MEK-mediated pathway activation is also going to be there. So NF2 would really help with BRAF. MEK inhibition would also help with BRAF, targeting the BRAF amplification. And additionally, there is also this cyclin D3 and CDKN2A, 2B loss. I think it's there in the next page. Now, the CDKN2A, 2B loss is normally seen in many tumors. It's a chromosomal loci loss. In few of the tumors, like that of breast cancers or pancreatic cancers, this CDKN2A, 2B loss is shown in many case studies to be sensitive to CDK4/6 inhibitors, your palbociclib or ribociclib. So looking at this report, there are three options one can see. One is a MEK inhibition by NF2, which targets both NF2 as well as BRAF. Then you also have a CDK4/6 inhibitor that targets this cyclin D3 and mainly the CDKN2A, 2B loss. Depending on FGFR3 amplification copy number, a pan TKI can be thought about in the later lines, but I really do not know how that's going to work out unless we see the very high copy number. So you can go back to the lab and ask for the specific, copy number is given here. 30, copy number of TERT is 33. Yeah, FGFR is 31. That's a pretty high copy number amplification. So if that is the case, another treatment option is lenvatinib, which can help with FGFR3 amplification. So these are my thought process here, purely based on the pathways and molecular analysis. But how these can be combined and what would be the right choice for this particular patient is something clinically we need to take it up.
Thank you, Dr. Arun. I'll share my thoughts before I go to anybody others. So my thought in this case is germline testing. No, I think just as I said for P53, same thing here also. If there is a phenotypic, we don't see melanoma in NF neurofibromatous. We do see other malignancies, schwannomas, neurofibromas, mesotheliomas, but melanoma is not a usual cancer we get in neurofibromatosis. So germline testing, no, unless the patient has significant family history and the patient has phenotypic features suggestive of neurofibromatosis, that is. And IO, yeah, I think it's a cold environment. We have seen patient didn't do well on IO. Within 4 cycles, I think patient has progressed. So whatever the NGS report we have, I don't think any SCAT level 1 or 2 recommendations we are actionable mutations we have. Whatever we have is not a probably it's unlabeled indication. And as Dr. Arun was
Arun,
yes.
What about the BRAF, Arun? Shall we try with
BRAF? It's not BRAF mutation. If you see,
mutation, it's only
it's a copy number. Same thing with FGFR also. It's a copy number variation. So if it's a mutation or fusions, probably FGFR inhibitors, we know there is a
yes, that is okay. But
here it is an amplification.
Can we amplification?
So that's why Dr. MEK inhibitors, Dr. Arun Kumar was telling, because it blocks the pathway down the lane. So MEK inhibitors, because MAPK pathway it's going to activate. So MEK inhibitors is unlabeled indication. Lenvatinib is a feasible indication, although we know we don't have much data based on this NGS. When all other options are exhausted, probably I do agree with Dr. Arun Kumar. It's a cheap, it's a patient can afford. It blocks the MAPK pathway. Yes, that can be tried. This is my thoughts. But level 1 or 2 actionable mutations we have. So options are very minimal in this case. Even best supportive care is not a bad thing to be done if the patient is sick and liver enzymes are elevated. Anybody else want to give their suggestions?
Hi, sir. Kripa here. So, like Mangai, this is an acral melanoma, right? Is that right? It's not a cutaneous.
Yes.
Or an acral melanoma. It's not cutaneous, is it?
No, sir. It is. I'm not sure about the initial thing, sir, because there is no reports. There is only a mention. But he had melanoma in his food, sir.
That's fine, but I think the report mentions it as acral melanoma. Is that right? Is it an acral subtype? Because, we've been assuming it to be cutaneous and all the discussions have been towards that. So, this behaves more like a mucosal melanoma if it's acral subtype. And that's why probably it's not responded well to IO as well.
So this patient, actually, I also seen in 2012, they did the surgery. The recurrence is after 12 years. So initial surgery is done from the dorsum of the foot.
Correct.
So,
but what was
so
that?
it was initially written as cutaneous melanoma only. But the recurrence, it is given as amelanotic melanoma, but we don't know whether the initial report is cutaneous, but again, we don't know whether it's acral or reported its previous reports. He didn't have whatever the written thing and other documentation, it's cutaneous melanoma.
Oh, for the right now, what the biopsy report, what is it?
It's amelanotic melanoma. So that's what they're given.
Then that probably, is probably another reason as to why the patient hasn't responded well here. And the other thing is, if you look at dacarbazine, temozolomide, both of them are similar drugs. They're pro-drugs which get converted to MTIC. The active metabolite is the same for both dacarbazine and temozolomide, number 2. And then this patient is, on directly acting antivirals as well for HCV and occult FP. So as far as the NF1 is concerned, I would also agree that you don't have to necessarily do a germline testing here. But again, we have MEK inhibitors that are approved for plexiform neurofibromas, NF1. Like selumetinib is already FDA approved for that indication. And likewise, mirdametinib as well, based on the RENU trial. So, they are approved. But here it will be an off-label indication if you're looking at targeting the NF1. But it makes absolutely molecular sense to do that, given that this patient has progressed on multiple lines and there's, not much to offer as far as standard of care here is concerned. But again, NF1, you're looking at targeting it through MEK inhibitors, and again, the BRAF copy number gain as well. And again, as was spoken about earlier, your multikinase inhibitors, MKIs, because there's an FGFR3 copy number gain as well. Again, you could look at using a lenvatinib also. But if the patient, got no financial constraints, I would also suggest going on to TIL therapy or tumor-infiltrating lymphocytes, which is already approved for melanoma, as far as Liflu-cel is concerned. And if you're wondering where to get it done in India, probably Dr. Vijay Patel in Mumbai is actually doing that. I know he's probably enrolling patients as part of a trial as well. So that's yet another option that can be explored. But I would definitely want to rule out whether it's, confirm whether it's actually a melanotic melanoma or cutaneous melanoma, because from whatever this molecular profiling here, it looks more likely to be an amelanotic melanoma, as has been rightly reported, doesn't fit in with the cutaneous subtype, as in at least right now. So I think you can probably go back and recheck on that, Mangai, and probably get your
Okay, sir.
that. And you can explore the possibility of TILs or tumor-infiltrating lymphocytes or Liflu-cel, which is yet another approved option. We don't have access to relatlimab, but given that the patient has already progressed on IO, I think TILs might be a good option here. You could look at doing that. And otherwise, off-label indication, you could look at blocking the NF1 by using MEK inhibitors like tremitinib, which is already available to us in India. So that's those are my thoughts on it.
See, this case, Nevo EP has been given, but 4 cycles, but didn't touch it, right? Like no response at all.
Exactly.
Nevo EP.
Correct, sir. Which is very unusual and quite
very unusual. Very unusual.
Cutaneous melanoma. So, which is why probably the amelanotic melanoma makes more sense here, sir. Which is why I was probably telling Mangai that you should get a pathologist to review the current blocks and see what type of melanoma it is. Because acral and lentigious, they don't respond as well.
Okay, sir.
And we know that. So I think, you should go ahead and check on that, Mangai.
Okay,
And as far as off-label indications are concerned, yes, you could do that. And as far as clinical trial options are concerned, lifileucel, but that's already an FDA-approved option as well, even for patients with refractory melanoma. Response rates are close to 30%, even in patients who post-IO failure.
Okay.
So that is for cutaneous melanoma, sir.
Correct. But here, that's why I said she has to go back and look at whether this is cutaneous or not, because you yourself said in 2012 it was cutaneous. And right
he don't have the biopsy
Exactly,
report,
we
but
don't
wherever
have
it's
the report, sir.
documented, it's written as cutaneous.
but I thought you repeated a biopsy now, right? Is that right?
Now,
Whatever the last decompression laminectomy, they have not reported as amyloidotic melanoma, sir. They have just reported as a metastatic melanoma. They didn't give the subtype and all.
Yeah, probably, it'd be worthwhile if there's any other feasible site also to look at getting a biopsy and also looking at checking on what subtype of melanoma it can be. Or even go back and if you can review the logs, or you can ask them to run or ask your pathologist to actually go back and clarify on that. It would be helpful.
See, I personally feel, submucosal melanoma, amelanotic melanoma, you don't have much trials. You need to go ahead, like as we do for cutaneous melanoma, at least for this patient, such a later lines we are discussing. Whatever that happens in cutaneous melanoma, we extrapolate, and we know this particular subgroup is not doing well, submucosal or amelanotic, but options are limited, right? So I don't think it's going to make a big difference here. Going back also, because we come to a later lines, we need whatever the data we have for cutaneous melanoma at a later lines. If positive trials are there, probably we need to extrapolate and use it here and try it.
No, agreed. I think, like I said earlier, if you're looking at approved options here, then probably, lifileucel is an option.
Yes, that's it. So
is an option.
Yeah.
Lymphocytes. So if your patient can access it or has access to it, or even as part of a clinical trial, if you can enroll it, good option. Else, you look at targeting the NF1 by using off-label MEK inhibitors, given that you have an NF1 mutation that's been picked up at a VAF of around 50%. So I think, I think those would be the options right now, as in right now.
What about the use of cabozantinib, sir, instead of lenvatinib? Can we try?
Again, all those are multi-kinase inhibitors, VEGF, FGFR, PDGFR, MET, and all of this works on all of these, right? So that's what we're looking at. But nevertheless, I think I would probably pick trametinib over cabozantinib or even lenvatinib here, because obviously the NF1 mutation seems to be pretty significant as far as the molecular profiling of this patient here is concerned. So if you want to ask me how I would pick it up, I would probably use trametinib here rather than the other TKIs, as the number one option here.
Okay, sir.
Fine. Naren, can you summarize?
This patient, 62-year male, after 12 years of surgery, now with the metastatic recurrence with the bone and multiple non-regional nodes, post multiple lines of therapy with based on the NGS, could either try for a MEK inhibitor or can go for a lenvatinib or can enroll in a trial for TILS. So this is the final consensus from the expert.
Thank you, sir.
Thank
you for all the input, sir.
Thank you. We'll go to the next case. Yes, Narendran, your case. You can go ahead.
Next slide. This patient, 61-year female, had a vaginal lesion for which wide excision was done, which was reported as vaginal melanoma in March 2024. She was advised for RT and adjuvant, but she defaulted. In September, after a year, now she has presented with a loco-regional recurrence with a bleeding PV and with liver metastasis, multiple liver metastasis. So she was started on palliative RT for the bleeding. Same time, biopsy from the liver lesion was, and she was NGS, and after RT, bleeding. Next slide. Next slide. So this patient, I just want to know, my plan is to go for any cisplatin with temozolomide and add on immunotherapy. So based on NGS, wanted to know what could be the next best line of treatment.
Okay. Thank you.
So-
Yes, Arun. So
Yeah,
we had
thanks.
the interesting two cases. One is HRD
Yeah.
positive. We didn't have any DNA repair gene positivity. Here we have a HRD positive, but there is a TP53 and ATRX mutation is there. Both are interesting
Absolutely.
cases. We'll see what Dr.
Sure.
Arun is telling.
So again, this is a HRD high. Again, caveat is that it's a lab developed test and there is a ATRX mutation. This is a loss of function ATRX mutation with a allele fraction of 35%, meaning it's definitely most probably not a germline variant. But looking at the question off-label targets, what can be done? So I'll give the molecular perspective here as always. So HRD positivity, definitely you can think of a platinum based regimen, which I think already has been mentioned. Secondly, I am not sure about platinum with temozolomide because both of them are work in a pretty similar way, if I'm right, because they cause changes to the nucleotide and cause cell death because of DNA damage. So whether insert, I think in this case, there is a RAF copy number gain. So RAF is your RAF1, if I'm right, is CRAF, if I'm right. So there is a copy number gain of RAF. In the next part of the page report, there is a NF1 copy number loss. So the RAF copy number gain is 9, pretty high, and it's a biallelic loss for NF1. Can you just go to the next page? You can see that. So again, as we discussed in the previous, this one. So NF1 copy number is 0 and RAF copy number is 9. So copy number 0 is a biallelic loss. So as discussed in the previous case, here the difference is that the whole gene is lost, meaning that here either the chromosomal level loss has happened, meaning the entire gene NF1 is not present. Whereas in that case, you had a NF2 point mutation that led to loss of its function. So here, I think one good target that you have based on the molecular report is your MEK inhibitor, because that will target both RAF as well as NF1. And HRD positivity suggests platinum sensitivity, possibly. And ATRX is again a DNA repair pathway related. So adding the platinum or any other related agent is definitely going to support ATRX mutation also. Your temozolomide working is also probably because of this ATRX mutation. So this is my takeaway. So
Thank you, Arun. I think others, Kripa.
Yeah, Naren. So what treatment has this patient already been exposed to?
No treatment, sir. Only RT. That too as palliative RT for bleeding control.
Oh, okay. Any reasons why you wouldn't want to do IO plus TKIs here?
Not a great experience with mucosal melanoma, sir, with IO.
So just to draw here, just as in the last case, this is a mucosal melanoma, but here also you're getting to see a sort of similar profile as far as the NF1 loss, RAF1 gain, as was Dr. Arun Kumar was also rightly alluding to. So this is definitely a mucosal melanoma for sure, a vaginal melanoma. So if you're looking at it, and this is the first line of therapy as well. I mean, I just wanted to understand, you're doing temozolomide and platinum because the patient has financial constraints or any other reason?
So one is the financial constraints. Another is this HRD is positive. Wanted to go for a platinum-based therapy. So either I wanted to add nivolumab low dose to this platinum-based therapy, or give only this platinum-based therapy. Because ATRX is positive and HRD is positive, so I, instead of going for immunotherapy, anyway, financial constraints is there. If I have to go only for low dose. So I thought we'll go for.
Yeah, if at all the patient is not keen on IO, then fine. Or if the patient can't afford the full dose of IO, then yeah, you're justified using the Dartmouth regimen, or the Dartmouth regimen also contains carmazine, platinum, and DTIC as well. So, you justified in doing that. But given a choice, I think the optimal treatment here, probably I would look at doing IO and add TKI to it, a multikinase inhibitor here in the first line setting. Because, I think, like we spoke about in the earlier patient as well, I think that would be our best possible, choice.
Kripa, here, see, instead of TKI, see, this is submucosal melanoma. They don't do well, actually. So EP-Nivo adding a CTLA-4 inhibitor along with the IO will be a better choice, right? So, or adding a LAG3 inhibitor, that will be a better choice rather than going for a TKI along with the IO, right?
No, sir. So the thing is, I mean, like if you look at it, like we already spoke about, the data as far as only mucosal melanoma is pretty scant and sketchy. There's no randomized phase 3 data looking at only patients who have mucosal melanoma. I think that's the case.
That study has included submucosal melanoma also, right? But yeah, it both EP-Nivo study as I think, and they found that in that particular setting, EP-Nivo was doing good, better than Nivo, right?
The problem is, sir, that was not powered adequately enough. That was a very small subgroup. So, we can't draw much from an exploratory subgroup analysis. There was not a pre-specified subgroup analysis looking at only mucosal melanomas. I think that's the caveat that we have always as far as melanoma is concerned. So, if you're looking at only extrapolating the data, nevertheless, like I said earlier, the reason why I probably choose an IO plus TKI here is because it's mucosal melanoma. Had it been cutaneous, then I would have just said IO plus IO or Nivo relatlimab as well, based on the relativity of 47 data as well. But here, I think, it makes sense for us to probably look at adding a multikinase inhibitor along with an IO in the first line setting. Simple reason, again, mucosal melanomas, incidence of c-KIT, roughly the tunes are around 9 to 10% as well. Even though this patient, we have not been able to pick up any c-KIT. Likewise. So I think, probably here I would edge towards, but I would definitely look at doing IO here in my first line. But since Naren has already pointed out that the patient has financial constraints and the patient can't go on IO, in that case, whatever his choice of platinum, along with, like I said, the Dartmouth regimen is not a bad option if the patient can't afford it, or even the DTIC plus tamoxifen regimen would also be another option if the patient can't afford to go on IO, sir.
Thank you, Kripa. I think my take, this is the first line actually, so better to go for standard of care, EP-Nivo or IO plus LAG3 inhibitor. Probably go for TK at a later line. That's what I think. And the patient is not affordable, then I think whatever Naren is telling, low dose IO plus platinum should be a good choice in this case. This is what I think in this particular case. Anybody else want to take have any take on this case?
My choice is also go for combined Nivo with IP as a first choice.
Okay.
If patient is not affordable, then you can consider TK can be tried.
Interesting,
Thanks, Kanan.
Probably would we do a low dose IO plus chemo or low dose IO plus TKI there? I don't know. That's an open question.
Okay. I think I will go for low dose IO plus platinum in this case, having a HRD positivity and P53 positive, ATRX is positive, and we have a HRD is quite high. Then if the patient is not affordable for EP-Nivo, then my choice will be platinum plus low dose Nivo in this particular case.
So I think all of us agree on the IO part of it. It's just that as the partner, because it's a mucosal melanoma, I think we have differing options. But I think, here also, I think the NF1 copy number loss and the RAFI, which, as Dr. Arun Kumar also rightly pointed out, indicates that the MAPK pathway is active. So it is a MEK pathway dependent molecular pathway that we're actually talking about here as far as this vaginal mucosal melanoma is concerned. That's probably what is driving it. Because we here also have an NF1 copy number loss and an RAFI, which is a copy number gain as well. So I think that's the reason why I probably said if the patient can't afford it, then probably low dose IO plus TK also is another option. But I think all of us would agree that definitely IO here in the first line setting, no doubt about that. And
TK means what TK? Whether trametinib you're meaning, sir, or you're meaning lenvatinib or cabozantinib here?
I would probably look at using trametinib only in this setting.
Okay.
Along IO. your patient can't afford the full dose IO, I'd probably do that. Because whatever, we've seen, I think, in practice as well, most of us would agree that, mucosal melanomas, the responses have been pretty dismal with only chemotherapy or even IO as well. In practice, I can tell you that. At least from my, I don't know, I will probably I'll ask Arun sir also. Arun sir, your thoughts as well in your practice.
Yeah.
What would be the
Absolutely. They do bad, but here that HRD positive is throwing some light at the end of the tunnel. Okay, that so thinking some platinum will do some miracle as it does for triple negative breast cancer. Okay, in this particular case. Okay, otherwise, cutaneous melanoma, submucosal melanoma is bad, and melanoma also is a bad subset. They do badly.
I think agreed. I think, in practice, I think all of us would agree that, these patients actually do the worst.
Thanks, Kripa. Thank you for the thoughts. I think if anybody wants to share any thoughts, otherwise we'll go to the consensus. Fine. Thank you
So
all. Yes,
so this
Narendra.
patient primary consensus is if affordable, go for Nivo with EP combination or
Yes.
Nivo with Lacri combination. If cannot afford, either you give chemo with low dose immunotherapy or you give low dose immunotherapy with the TKI. This is the consensus. So that is.
Thank you, Naren. I think you concised it well. We'll go to the next case then. Tamal, can you go to the next case? Yes. Okay. The next case is by Dr. Lakshmi Tilak, Meenakshi Mission Hospital, Madurai.
Good evening, all. Hello.
Yes, you are audible.
Yeah, thank you, sir. So it's a 69-year-old female diagnosed as metastatic carcinoma pancreas in April 2025. Then she started on palliative chemotherapy, received 6 cycles of gemcitabine with paclitaxel. After that, the follow-up PET-CT was done, and which shows a progressive disease, and she was changed to a chemotherapy, that is weekly IFL chemotherapy. She is not having any family history. Significant family history was present. Next slide. Next slide. It was a pancreas lesion biopsy, was a moderately differentiated adenocarcinoma. Next slide. So as I already mentioned, after the 6 cycles of gemcitabine paclitaxel, the follow-up PET shows a progressive disease, and now she is on weekly IFL chemotherapy. So we had her NGS done, and the NGS report shows in DNA variation result, there was a clinical significant variation detected, that is KRAS, that is glycine 12 aspartate, that was detected in GNAS also detected, and CDKN2A also detected in DNA variation result. In RNA fusion result, there was no clinically significant gene fusions detected, and tumor mutational burden is very low. Next slide. Next one. Next page. Mutation is low and the MSI is stable. So this is our NGS report, and DNA report. There was no next one. No pathogenic or likely pathogenic cause of reported phenotype detected in DNA test report also. So based on this NGS report, any targeted therapy is available for this patient.
Okay, so I'll jump in here.
Yeah.
I think the patient is already given the first-line therapy and
Yes, sir. Yes, sir.
doing well now.
She had progressive disease, sir.
Progressive disease. Okay. So, what I'm suggesting is again purely based on molecular report, and there is so this particular 3 gene mutation. If you can go to the
can you go to the NGS report, please?
NGS report. So the KRAS CDKN2A to be loss as well as the GNAS mutation is a very classically seen genes mutated in a subset of almost 30-40% or more of pancreatic cancers. Now, Dr. Reyes Kursrock, one of the leading precision oncologists from US, most of you would be knowing, she did a very wonderful publication in 2023 on matched target-based therapy in pancreatic cancer. So I can share the paper here in my screen, or I can just tell it orally. So you may be knowing this iPredict study, very similar to that. What in that paper they did was every gene, say if there are 3 or 4 gene mutations, if you're able to target all the 4, your matching score is 100%. If you're able to target 2 out of the 4, your match score is 50%. Now, in that pancreatic cancer paper, what she identified was that if the match score is more than 50%, the PFS and OS benefit was significantly higher. And that too, if it is in first line, it is much more higher. Now, 6 out of 11 patients had a PFS of more than 6 months. And particularly the patient who had a GNAS mutation, KRAS mutation, and NF1 mutation, who were treated with trametinib and CDK4/6 inhibitor, had a PFS of 13.6 months. Now, molecularly, what is happening is KRAS activates the RAS-RAF and the MEK pathway. GNAS also activates the MEK. So a MEK inhibitor would target both KRAS and GNAS. The CDKN2A mutation, this is a loss of function mutation, and that loss would be targeted with the CDK4/6 inhibitors. Now, purely based on this paper, and also few of my experience in other tumor boards where I have seen this combination work in second, third line of pancreatic cancer, especially those having the KRAS mutation in the G12th region and the CDKN2A loss. So this is my takeaway, but whether you have other approved indications in the second line is something you would want to see before trying this out, because this is not an approved indication.
Okay.
So yeah, Kripa here. So I mean, like, what was the first line of treatment here that was given here?
Gemcitabine paclitaxel.
Oh, gem and nab-paclitaxel. Okay. So I think here then obviously you have options of nanoliposomal irinotecan, NALIRI, right? NALIRI as well, which are all approved. I can't. Sorry, I can't hear you, Naren, again.
A patient progressed on 2 lines. The second line they given irinotecan, I think.
No, IFLs we started, sir. After progression, we started on IFL.
Oh, right now the patient is on IFL.
IFL, weekly IFL.
Weekly IFL, okay. Fair
6 cycles of gemcitabine paclitaxel, then progress, now on IFL.
Okay, but has never had a platinum? Has never had a platinum until now, right?
No, sir. No, sir.
Okay. So I think, probably I would also look at adding a platinum-based tablet, or, using nanoliposomal irinotecan-based combination. And once the patient progresses on that, then like Dr. Arun Kumar has rightly pointed out, this is a non-G12C. And non-G12C KRAS, which has been picked up, and Tier 2C, likely pathogenic driver here. So it's a G12A. So, you could definitely look at target the downstream signaling pathways by using a MEK inhibitor. CDK4/6 inhibitor, again, the problem would be, when you combine it, the question is about toxicity. And the data that Arun sir rightly pointed out, the numbers were not too large. But like you rightly said, it's an off-label indication. And you could do it for the late lines of therapy. Once you've exhausted all the standard of care options, you could look at doing that. Again, the concerns there would be about if you're looking at combining MEK with a CDK4/6 inhibitor, would be the concerns about toxicity. But MEK inhibitor, yes, definitely yes. Would look at doing that, but not now. Probably for late lines of therapy. Like I said, once you've exhausted your platinum and your nanoliposomal irinotecan, then probably yes, you could look at doing that. That would be, and again, there are trials which are looking at enrolling, pan-KRAS inhibitors, even in pancreatic malignancies, and particularly for G12D, KRAS G12D inhibitors as well. Deroxanrasib is a class and example. So I think, again, access to clinical trials, if you have access to it, that is also another option. Else, you could look at doing a MEK inhibitor, but that's for later lines of therapy. Like I said, once they've exhausted your platinum and nano-liposomal irinotecan, which the patient has not been exposed to, and it's a very tumor cold microenvironment, so no role for IOs here.
Okay, sure.
Your suggestion is to continue in IFL if there is a good response, then next line with the platinum-based therapy and progression, you consider off-label therapy.
Correct.
Okay.
Thank you, Naren. I had some internet issues, so I was just out. I took some time. I think your you made the consensus, right?
So this
Naren, you
patient with
documented that.
metastatic pancreas, sir. So
Yes,
post gem PACLI progression
Okay.
on IFL weekly now, irinotecan 5-fluorouracil. And now this patient has KRAS GNAS CDKN2A amplification, CDKN2A mutation, sorry. And if this patient, the final consensus is, as of now, on second line to continue if there is a response is good. Third line may consider a platinum because not exposed to platinum. And further lines may consider a combination of MEK inhibitor with CDK4/6 inhibitors as an off-label treatment.
Okay. Okay, fine. I agree. There is no actionable mutations now. Probably repeat NGS at that point of time will throw more light what we are going to do. As of now, I think NGS based
There is a
treatment is
paper which Arun Kumar sir suggested. So there is a case report where this combined mutations, KRAS and the CDKN2A mutations, they have a good PFS with the combination of MEK inhibitor with CDK4/6 inhibitor. So he was explaining those, what is the PFS and all. Yeah.
Fine, Narendra. We'll go to the next case.
Next case, yes.
10 to 15 patients were included in that series, I think. Is that right, Arun, sir?
Yeah.
Yes, sir. Yes, sir. So 11 patients received more than 50% matched therapy. And I think 7 or so received less than 50% matched therapy. Because this is just pancreatic cases, not all tumors.
Right.
Okay. Okay. Thank you. So I will go to the next case. This is one of my case which I'm presenting. Next slide, please. So she's a 69-year-old female, carcinoma ovary, diagnosed since 2019 with multiple comorbidities. Next slide, please. So she had almost 4 lines of chemotherapy regimen. So she received initial Taxol carbo, then Gemset carbo, then weekly nab-Taxol was given. After that, metronomic oral VP16 was given. Then July 2025, she had progression. So at the time, lipodoxisplatin was started. Next slide, please. So next slide. So next slide. So in this case, a 69-year-old on second cycle of lipodoxisplatin, we did a rebiopsy. We sent that biopsy for mutation testing. So this patient had HRR gene panel also testing that was done 4 months back. She didn't have HRD. HRR was done, which was negative. This time we sent for comprehensive genomic profiling was done. So here we found KRAS mutation was there, MSI was low, and TMB in this particular case was 11 mutation per megabase. So this is the report of this particular patient. Otherwise, no other significant mutation was there. Next slide, please. So this is the continuation of the same report. Next slide. Next slide.
Reached to the end of the report, sir.
Yes, this is the end of. So, so this is the patient. So my question is, like, what is the role, even in the keynote study, if you take the subgroup alone based on the TMB, the response was not good. Although it got a tumor-agnostic approval, can we add immunotherapy for this patient? After 2 cycles, she didn't tolerate chemotherapy. She is not willing to continue further chemotherapy. Will IO alone as a single agent, will it work? Although it is approved, will it work? So what is the thoughts of the forum on this particular case, offering a IO based on the TMB report?
Not a big fan, sir.
Generally, IOs are not working well in CA. I thought
Okay. Okay. Thank you.
And here it is just borderline positive.
Okay.
And see, the cutoff of 10 was based on Foundation Medicine's panel. Now here, this is a different, I think it's a 500 gene panel of Illumina, if I'm right. So whether the same 10 cutoff, that too in a borderline, is it going to work? I'm really not sure. That too as a single agent, really scared.
Yeah.
Okay.
Again, Arun sir, probably, I mean, if your patient doesn't have financial constraints, folate R1 receptor testing, FOLR1 receptor testing, platinum-resistant ovarian cancer, number one. And again, right now, recently, we have the Keynote B96 data that is presented at ESMO as well, which is looking at the addition of Pembro to nab-paclitaxel and bevacizumab in platinum-resistant ovarian cancer. And that has shown a significant PFS and an overall survival benefit as well, to the tune of around 18 versus 14 months. So you're talking about an absolute improvement of close to 4 months in platinum-resistant setting, and 8 versus 6 months of PFS benefit. So, I mean, like, again, not yet approved, but the phase 3 data has been presented at ESMO.
Any subgroup that benefited more in this particular subset, subgroup analysis, which had maximum benefit, anything like that?
This was irrespective of the PD-L1 expressions. So both PD-L1 negative and PD-L1 positive seem to benefit more. But they looked at patients who had PD-L1 CPS more than 1. And that you know, as a subgroup, like you rightly asked for, probably did seem to benefit more. So, but here it was non-selected. They only looked at patients who had platinum-resistant disease. They did not select patients based on the PD-L1 or the MSI or TMB. So that's the data that we have. That's pretty recent data. But if you're looking at it otherwise, you know, there's the other Rosella trial as well, looking at relacorilant plus nab-paclitaxel. I think it's fair enough to say that in the platinum-resistant setting, now our standard of care has become nab-paclitaxel with bevacizumab, plus or minus if the patient. I think we've moved away from all the others. So I think because all the current trials have the control arm as to be like that. So to me, I think IO alone in ovarian cancer, not a great fan. But in combination, yeah, probably worthwhile, you know, contemplating it in this sort of scenario. But I would, my order of preferences would be to check for a folate R1 receptor, for folate receptor 1 alpha testing on IHC. If positive, mirvetuximab soravtansine. If not, my second go-to option would be, again, nab-paclitaxel bevacizumab with pembrolizumab as a combination based on the Keynote B96 data. My third option would be relacorilant plus nab-paclitaxel based on the Rosella data, albeit the last two options are not yet FDA approved. The first one,
this patient has already received nab-taxol bev 1 year back. Would you like to re-challenge nab-taxol bev along with Pembro in this patient with the new data, new NGS report, what we have?
Correct, sir. Because, you know, what is the platinum-free interval as well, sir? Here, I mean, like, when was the last?
Almost a year. She didn't agree for any IV chemotherapy for a year.
Okay,
so it is almost a year since she. But initially, second time when she came, she was platinum resistant because she didn't respond to gemcarbo. After 4 cycles, she progressed. So she was labeled a platinum resistance. But pre-interval now is almost a year.
Yeah. So in that case, I would definitely look at re-challenging, sir, and add a platinum as well, because it's been more than a year now. And if the patient agrees to have IV chemotherapy or is willing for it, then I would definitely look at re-challenging, because even in platinum-resistant disease, we know the Vanderberg protocol, etoposide plus platinum, response rate is close to 100%, even in that setting. So I think to me, if more than a year, I would look at re-challenging.
Thank you, Kripa. Thank you very much.
Option of adding a MEK inhibitor to immunotherapy here if patients not willing for IV chemo.
Based on the KRAS mutation.
Mutation.
Okay.
In the data on that, Naren, had this been a low-grade series, you know, the data there is pretty compelling, because, you know, I mean, like we have trametinib approved there as well. Again, in low-grade serous ovarian histologies, where we know around 30% are likely to have the KRAS pathway involved or the MAPK pathway involved. So I think, you know, in that sort of scenario, yes, I would probably look at using it. But, you know, given that if it's high-grade serous, then I would probably look at doing this before moving on to looking at targeting or using a MEK inhibitor.
Okay.
Thank you, Kripa. Yeah.
Other approval Low-grade serous is also avitumetinib plus defacitinib, yet another BRAF plus MEK inhibitor that's approved in low-grade serous now. In patients who have pathway alteration or the RAS-RAF pathway being involved. That's another approval that we have based on the RAMP 201 data, the phase 3 trial, and it's approved as well. Avitumetinib plus defacitinib. Like yet another BRAF plus MEK. They call this the clamp inhibitor, BRAF MEK clamp.
Okay. Thanks, Kripa. Ms. Naren, can you just summarize, and we'll go to the next.
This patient post platinum resistant CA were not much keen on chemotherapy. Now with KRAS mutation 5 and TMB borderline, the consensus is to check for IHC for polar, and if it's positive, then go for mirvetuximab. The next line is not yet FDA approved, but we have phase 3 data from the recent ESMO, the combination of MAPK with immunotherapy with bevacizumab. So if later lines of treatment may consider off-label MEK with immunotherapy if these options are exhausted.
Thank you. Arun Kumar, what the TMB you will consider as like significantly positive, Arun Kumar? Like we have a cutoff of 10, so that's most of the reporting happens. We don't even get the exact report. Sometimes we TMB positive and it's more than 10. It comes. What is a significant positive as far? Does it vary by cancer to cancer, site to site?
Actually, yes, sir. So now the thought process, although it's not at in the guidelines, is to have a tumor-specific cutoff. So there has been one very nice publication from Indian laboratory itself, where they had compared the TMB across multiple tumors, and the median TMB varies with every tumor. So we should see for that particular, in this case, ovarian cancer, let me say, hypothetically, even a TMB negative, the median is somewhere around 8 or 9 mutations per MB. Then 11 is not really a high TMB for an ovarian cancer. It's just hypothetical. I don't know the exact value. Whereas for some other tumor, if the median is somewhere around 2 or 3 mutations per MB, 11 is really high. So whenever it is in the borderline, say it's 9 or 8 and 11 or 12, I would still consider not to be using a monotherapy, but using a with a chemo addition is what I would think of. And moving forward, we should start looking at the median TMB in the particular tumor to see in which percentile the patient's TMB is coming into. But again, the challenges, practical challenges is the labs vary, the panel size varies, the estimation varies. So these are all certain practical challenges one has to keep in mind. But as I said, this is an evolving thought. So sooner or later, we should be looking at tumor-specific TMBs cutoffs.
Okay, thank you, doctor. Yeah. Okay. We'll go to the last case, actually case 7, Dr. Mridul Malhotra from Manipal Hospital, Dwarka, Delhi. Dr. Mridul, you are here?
Yes, sir, I'm there.
Yes, over to you, Mridul.
Yes, so probably, so I think there are the slides.
You can start the presentation.
Yeah, so this was a 62-year-old, I hope I'm audible, right?
Yes, yes.
Yeah. So this was a 62-year-old lady who was diagnosed as CA breast. Actual initial date of diagnosis was November 23. But at that time, she probably took alternative treatment. She was diagnosed with a metastatic breast cancer, bilateral breast, with involvement of the nodes in the neck, bilateral axillary nodes. And it was probably inflammatory also at that time on the left side, and on the right side it was involving the retroareolar area with the skin at the neck, and there were a few metastases in the bones. So but that time she took alternative treatment in November 23. After that she presented to us in April, and in April she was again having a progressive disease, so she came to us. So we started her on treatment based on her previous biopsy done in November, which was ER 8+, PR 8+, HER2 new floor was 1+. And so we gave her first line of treatment with ribociclib and letrozole, started in May 2024. She took that comfortably for 1 year. She had a partial response to the treatment in the PET scan done in October. And then they were not very compliant on follow-ups and this thing, but they were continuing the treatment. And in 1 year later, after 12 months, there was a progression in the bones, in bilateral breast lesions, and in the lung nodules, and in the nodes also. And there were new onset bone metastases. So again, she was advised to get the biopsy done, PIK3CA mutation, NGS repeat biopsy, but she was not willing. So we continued ribociclib and gave her fulvestrant along with the CDK4/6 inhibitor. 3 months later, in August, she was evaluated. Although she was asymptomatic, but with a PET scan, there was progression in the bone, in the nodes, and then the breast lesion as well. So we this time we asked her to get the biopsy done. She got a biopsy in September 2025, and after progression on 2 standard lines of treatment, she was started on systemic chemotherapy with the paclitaxel carboplatin. We have sent NGS, and we had also sent it for the IHC to see what has happened. Unfortunately, the blocks were taken up for the NGS, but IHC is still pending. She has come now today for cycle 2, and we have asked her to get that IHC done. If somebody can share the NGS report. Yeah, this is the NGS report. So she is basically showing HRD gas. So this is genome. It is a comprehensive genomic profile. So gas45 was positive, PIK3CA was positive with a VAF of 58%, ESR1 was positive, and in the next page there was ERBB2, that is HER2 new, was also amplified with the copy number of around 10. And so if there can be the next page, please. Can you take to the next page? Yeah, ERBB2. So it is, if you see the last line copy number of ERBB2, it was 10. So ERBB2 is amplified, and then there are other MIK and MDM4 and FGFR1 also. So I just wanted to discuss, a patient is not very affordable for HER2, and the IHC is still pending. We want to know what is the status of HER2 new and ERPR and HER2 new. So started right now on chemotherapy, asymptomatic, probably she should respond to it, but what would be the next best line of treatment for her?
Thank you, Dr. Mridul. I think a very interesting case. I think we can see the driving mutation. We can see the endocrine resistant pathway. It's a very interesting case. I think because a lot of positivity is there in the NGS report, we'll go to a molecular specialist. I think Dr. Arun Kumar, Dr. Pushpa, anybody wants to start?
Yeah, sure, Doctor. I mean, so very lot of things happening in this tumor. First thing is resistance to hormonal therapy. Very clearly, we are able to see given the array of mutations, both PIK3CA as well as ESR1. So both of them do show resistance to hormonal therapy. There is also this MDM2 and a MIK and FGFR1 amplification. So MIK, I think I spoke in the beginning. Again, it's it tends to, MIK amplification tends to cause resistance to chemotherapies, including platinum-based chemotherapies. And HER2 is amplified. I think so. The most attractive target here seems to be the HER2. And but the doctor has already mentioned the TDXT is not affordable for the patient. But apart from that, I don't know how whether dual HER2 inhibition is going to be an option here. If that is the case, or TDM1 is something that one can think of. But otherwise, given these, there is a lot happening in the genome. There is a lot of copy number alterations, which itself shows the genomic instability to be somewhat happening. But please don't go with this high of the genomic HRD score 45 being high, because earlier we saw scores of 70 and 80. So I'm not sure what is the cutoff for this particular HRD score in this particular lab. But otherwise, I think the most attractive target is the HER2 here. Thank you.
So, Dr. Arun, if I may ask, can we target HER2 based on this NGS report, or we just need a validation with the IHC and FISH?
I would suggest to do an IHC, but this seems to be pretty sensitive. Generally, HER2 is the gene in which labs use to develop their bioinformatic algorithm for copy number variation. So I generally don't think you could have false positives in HER2 copy number by NGS, but nevertheless worthwhile to test a HER2 IHC also.
All right. So is it you're taking a cutoff of this HER2 new to be more than 6?
So generally 5 or 6 is borderline positive. Here it is 10. So I expect the IHC to be around 2 plus, if not more.
Sorry, how much? It got
2, 1.5, 2.
Because the baseline I heard. So there are lots of things in this cancer. Actually, one is that probably she had a bilateral breast cancer. Okay. We only had a biopsy initial because there was reluctant from the one breast only, because the patient was reluctant on a lot of treatment. As you can understand, she took alternative treatment for initial 5-6 months, and then she failed, and then she came to us. So we did not go ahead with a repeat biopsy or with the biopsy of the contralateral breast. So initial biopsy was from the left breast. It was strongly hormone positive. HER2 new was 1+. After that, she responded well for over a period of 1 year, but then she has subsequently failed the hormonal therapy, first line and second line. And now we repeated a biopsy. It was from the contralateral breast and supraclav node. So probably a lot of heterogeneity, and definitely I will cross check as per your recommendation with the HER2 new IHC and FISH as well. Thank you, Dr. Arun.
Dr. Arun Kumar, for me, if here HER2 is for NGS has shown CNV copy number variation with a score of 10, and there is like bilateral breast cancer. We don't know what is a cancer. We are going to do the biopsy, which exact site we are going to do biopsy and IHC. Even if IHC is negative, it comes negative in this particular case. We know that earlier it was negative. I think, is it not prudent for this case? We can add anti-HER2 even if IHC is negative. The patient is already on chemotherapy. Irrespective of IHC, we can target the HER2 new, right? With this NGS report.
We can, sir. We can. And I believe it was HER2 1 positive in the beginning. IHC.
Yes.
Correct.
And
so,
what
but
the HER2 report? I mean, like, what
now,
is the IHC, current IHC on the repeat biopsy, HER2?
Sir, it's been sent. Actually, we had sent both of them, NGS and IHC, but right now the patient only got NGS. So we are pushing on that. We should get that in a couple of days.
Yeah, then probably I think you should get a FISH done as well, because the HER2 sub-17 ratio, and probably tell you as well. Have you sent for a FISH as well?
Sir, reflex.
No, reflex means only if it's equivocal you do a reflex, or are using a different probe. That's a dual colored probe you're talking about. You first have to send for a FISH, right? I mean, like you're waiting for it to be 3+U. Is that what you're trying to tell me?
Yeah. Yes, sir.
Okay. So then I think you wait for that.
Kripa, for my thing is here FISH can still be negative. If the copy number variation is there, IHC can be positive, FISH can still be negative, and CNV can be high, right?
So the only thing is, sir, right now, if you look at all of the data that we have, the current approvals for HER2-directed therapy, apart from TDXT, where we're looking at HER2 low and ultra low, it's only based on IHC and FISH, sir. I mean, like none of the for only trastuzumab or pertuzumab or all the other HER2-targeted agents are based on just the copy numbers alone, sir. So I think if the patient can afford TDXT, then there's no doubt. We can take this as low or ultra, even ultra low, and go ahead and offer TDXT as part of HER2-directed targeted therapy. But given that this patient cannot afford TDXT, then I think makes sense for me to look at doing a FISH as well. So.
Yeah, my thought is, if CNV is high, IHC should be positive. If IHC is negative, then it is a tumor heterogeneity. Probably multiple clones are there. but fish can still be negative in this particular case.
Correct, sir. But then again, earlier also it was 1+, and we know 1+. Also, the incidence of fish being positive in 1+ is pretty low. Say 2+, we talk about around 50%. But 1+ can also be positive. We don't know, which is why probably it's better off if you wait for the IHC report right now. If it is 2+, then it's sort of solves the conundrum.
Probably
if
IHC is negative, probably rediscussion we should have, right?
Yeah. If IHC is negative, I think getting a fish is in order, especially if it's 2+.
But Dr. Kripa, irrespective of IHC or fish, if the therapy is going to be with TDXD, would all of these again be required? I mean, it's just academically I'm asking.
No, very true, sir. Like I said earlier, I think for TDX now, because it's, if you can take this as HER2 low, because the earlier upfront biopsy also is 1+. So that means it's already HER2 low. It's already HER2 on the earlier tumor biology as well. And even if it's ultra low, now we have the data to use TDXT. And pretty interestingly, there's a trial called Daphne trial where they're looking at HER2 0 as well and TDXT in those sorts of patients. So pretty soon it's got TDXT for everyone. But I think until we stage,
with this report, actually, I think the TDXT can be given even without waiting for IHC report, because again, there is a high tendency that IHC may also turn out to be positive here, sir. And even if it is 1 or below ultra low, as a Destiny trial tells now, TDXT will work in this kind of patients, even if.
Rightly, I think the current approval right now is even for low and ultra low as well.
Ultra low also, yes.
Which we call a 0+ on IHC. So I think if that's the case, then yes. But if your patient cannot afford TDXTs, that's when the question really comes up as to what you would do. Because I think none of the other drugs that we have access to as far as direct, targeting HER2 are concerned, work in HER2 low or in ultra low settings, which is where, your overexpression and amplification really does matter. So, I mean, like if you're looking at using all the other MABs or TKIs that are already approved in the HER2 positive space, given that that's likely to be a triple positive disease here as well. We're talking about somebody with triple positive disease, given that the PIK3 pathway also is active, and we know that's one of the mechanisms of resistance as well. So I think here it's worthwhile going ahead and rechecking after the IHC report is done, and if it's 2+, you will look at getting a fish done. If it's plus, then I think that solves the conundrum. That says yes.
Thank you. The other discussion in this case is the ESR1 mutation and PIK3CA mutation. If HER2 is negative IHC, okay, then endocrine pathway is resistant. There is a PIK3CA mutation, but up there in the receptor level also we have a ESR1 mutation is there. So how do you see this particular changes that's happening, Dr. Arun Kumar, and any other molecular specialists? What is the endocrine pathway for this particular patient? Or there is no point in for targeting that endocrine pathway?
Sir, ESR1 being positive here, basically. So definitely that is a resistant marker for your endocrine therapy.
And I think
so
also the
any
patient
role
is not.
Yes, Kripa, proceed.
I think patient has not been exposed to any of the PI3K inhibitors, so I think capivasertib is another option definitely. And if in case we think it's HER2 negative, then I'm talking about in that sort of a scenario where again capivasertib with fulvestrant or even with elacestrant as well, because looking and targeting both the ESR1 and the PI3K inhibitor pathway, those are options. And again, even if it's hormone positive, sacituzumab govitecan is also approved for a hormone receptor positive metastatic breast cancer post multiple lines. You could do that. That's also an option. If it is, again, like I said, HER2 negative, that's the ADC, govitecan, SG is also approved. So I think we have multiple options, but it'll all boil down to the receptor status now, and especially the HER2 status.
Yeah, I just want to add one more point, or rather a question here. If we are, all the hormone therapy is going to be only if it is HER2 negative, as Prashankar rightly said. But if it is HER2 positive and the patient is not able to afford a TDXT, would a dual HER2 inhibitor with a PIK3 mutation, because PIK3 we know is also a resistance pathway for anti-HER2 therapies. So without a ADC, targeting the PIK3, targeting the HER2 would also be not prudent in my opinion. What is your thought, Dr. Krupa?
Agreed. I think, if you look at it, like, for example, now we have the data to even look at using CDK4/6 in combination with hormones with dual HER2 blockade.
Yeah.
Now that's shown the Patina study, 45 versus 30 months, 15-month absolute improvement in PFS. So I think we're getting to that stage. Again, even the Monarch HER as well, in triple positive disease, we're looking at Abima plus fulvestrant plus trastuzumab as well. So yeah, agreed that you could look at doing hormonal therapy and combining it with dual HER2 blockade in this setting. But like I said, that'll be prudent if the patient turns out to be HER2 positive. And, if it's 3+ or 2+, and then I have FISH being positive. Yep.
Thank you. I think in this case, getting the IHC on the HER2 new status is the most important. That will tell what will be the further lines of treatment. So, Naren, can you summarize?
Just a doubt here. Even if an IHC is 3+, patient cannot afford transfusion of deruxtecan. We are contemplating to do positive to add trastuzumab along with chemo. That's what this discussion is going on, no?
Yeah, that's what I actually was trying to ask, because just blocking the HER2 externally without a ADC in the presence of a PIK3
Suppose
mutation.
if it's just positive alone, we can, because here the copy number gene also can make IHC positive.
If its HER2 is becoming positive, it will be the first line treatment. Probably we know that they will progress fast, and some point of time we need to add TDM1 or NR2. But we know that the progression-free survival is going to be small. But still, I think to start with, either we need to start with TDM1 or pertuzumab, trastuzumab in this particular patient. If HER2 is becoming positive, the patient can afford NR2, then there is no discussion at all. But whether in this patient upfront you will start PIK3 inhibitors along with hormones, along with anti-HER2, I think most of us will think of adding chemotherapy along with anti-HER2 reagent rather than.
The FISH discussion is only for reference.
Yeah, correct. So, Naren, I think, we should the presenter, if the presenter is around, what has been the response so far to your Paclitaxel and carboplatin? Patient is on Paclitaxel and carboplatin, right? And that's what.
So right now, yes. So she's received second cycle today. We're giving her 3 weekly chemotherapy, and she is always being asymptomatic. So just 2 cycles down, maybe after 1 more cycle, we'll evaluate the response. But as such, clinical response is there.
Oh, okay. So I think, then I think if the HER2 positive, adding, dual HER2 blockade to your taxane backbone, I think that's what most of us do. And once the patient goes off, then you can combine it with hormonal therapy. If the HER2 turns out to be positive. I think finish off your chemo plus HER2 blockade, given that the patient is responding, and taxanes plus HER2, dual HER2 blockade. And then once the patient goes off taxanes, put them on hormones, or even your PIK3 inhibitors or your AKT inhibitors as well, along with hormonal therapy and dual HER2 blockade.
Okay, just one more thing if I wanted to ask. There's GAS45, some mutation which is saying that there is could be a potential to target with the PARP inhibitors. So what are your thoughts on that?
No, which mutations are? Sorry.
I think GAS45.
Is it there?
Talking about HRD, sir.
Oh, okay. Genomic score. Yeah. So that's what I said before, because this is a laboratory developed test, and I'm not really sure the cutoff of this. Previous cases, we saw the patient having a score of 70 or 80, but this is 45. So I presume there should be, or I assume this should be just weakly positive or just borderline positive. And I don't see any other gene mutation which can explain this genomic scar score. So, or this genomic HRD score. So I'm not really sure if the response to PARP inhibitor is going to be as good, primarily because we don't know how this particular HRD scoring system works and how response to PARP inhibitors are. But if your platinum response is good, you could use that as a marker. That's it.
Thank you, Dr. Mridul.
Thank you.
Dr. Mridul, as we discussed before, HR, we do see BRCA1 and BRCA2. HRD, we do give more importance in ovary. That's how the trials were designed. So when we get a HRD positive in breast or prostate, we always need to see what is the gene that is altered along with the HRD positivity. That is the one which will make us take a decision. Yeah, as Dr. Arun Kumar said, we have a HRD positive that too in a lab developed its own test, but there is no associated DNA repair gene mutations or alteration we are able to see. So we are not very confident in this particular case to add PARP inhibitors based on that HRD report.
Thank you, sir. Thank you. Understood.
Thank you. Thank
Sir,
you.
and one more point to add over here is basically GAS score, what these people are mentioning. So we need to first understand what are the parameters they are including to give this score, basically, whether it is loss of heterozygosity alone, or it's a combined score of all these three, or it is based on any BRCA GNAS or something.
Okay. Thank you. Thank you for the inputs. Thank you all. I think we have completed all 8 cases. Dr. Kannan, your final points for postgraduates or people here, and we'll wind off.
Thank you, Arun. Thank you, panelists. Thank you, presenters. Nice discussion. Then, for the bit of postgraduates, if the patient is having weak positive hormone receptor status, then you have to be very cautious about choosing the hormone therapy along with CDK inhibitors. They will behave more for triple negative in those subsets. You have to be very careful in selecting the therapy. In multiple syndromes malignancy, multiple synchronous malignancies, without germline mutation, it's better to do a somatic mutation in each and every subset so we can look for any targets if the patient is having a metastatic disease in the lateral lines. If you are having any approved, if you don't have an approved indication, then choose the indication, choose that approved therapy initially, then go targeted therapy as the lateral line you can choose. Then regarding HRD, still we have no consensus about the usage of PARP inhibitor.
Hello, Dr. Tamil? Yes, Kannan. We lost you in the middle. Yes.
Yeah. IO in the setup of ovary in the borderline TMB status, it's usage of IO as single agent is not at all advisable at this point of time. We can combine with chemotherapy or with VEGF inhibitors along with IO. These are some of the take-home messages.
Thank you, Dr. Kannan, for sharing the whole session. I thank all the admins, Dr. Arun Kumar, Dr. Kripa Shankar, Dr. Narendran, Dr. Saju, Dr. Chandralekha, all the admins. I thank all the experts, Dr. Arun Kumar, Dr. Pushpa, Dr. Brinda. I thank all of you for giving excellent insights over the cases. I thank all the presenters to come here and to share their cases with us. Thank you. Have a nice weekend. Enjoy your Sunday. Thank you very much.
Thank you all.
Thank you all.